Welcome to the Real Integrative Medicine podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, guys, welcome to another episode of the Real Integrative Medicine podcast. Get ready to put your earbuds in, listen to this very intimate conversation we are about to have about sex drive, about vaginal dryness. I am joined today by one of my good friends and colleagues, Dr. Dolores Fernandez, who is an amazing naturopathic doctor, but also is the founder of Iris, which is a personal care company that specializes in lube and vaginal moisturizer for all people. We're going to talk about a lot of important things here today. Dolores, thank you so much for spending time with us, and welcome to the show.
Thank you. I'm excited to be here and talk about such an important message, actually.
So I would love for you to give us a little bit of your journey for how you got here. It is not every day that we have a naturopathic doctor who has taken the retail world by storm, looking at personal care products. And I love this discussion about your background and how you got to this place of really being so frustrated with what was available on the market for people when it comes to vaginal products. So I'd love if you could walk our listeners through kind of how you got to this place, because I think your passion around this really speaks volumes about the importance of the topic.
Yeah. I always joke and I say that this field found me. I really never left school thinking I was going to have a focus in never mind products, but even like sexual wellness, vaginal changes, menopause. That wasn't really what I had set out to find. But naturally, that's just kind of what found me. Right out of school and into practice, I walked into a very busy practice, and almost every person that walked in was coming in with concerns around menopause. I felt I didn't feel very equipped to treat these people. And so naturally, the first thing I did was try to figure out where I could learn. And I would say, it's no fault to the school that we leave there with very little menopause training. What we do leave with is the ability to learn how to learn and learn how to find things. And so I felt really good at that. I felt like I can figure this out. I can turn to the research. I can see what other organizations are doing this. And so that's what I did. I found some leaders in the field, both in our profession and in other professions, who were kind of really paving the way in menopause care. And so pretty quickly, very busy menopause practice. And I was so interested in vaginal wellness and vaginal changes that happen in menopause because I was blown away to learn that up to 85% of people are going to experience vaginal changes in menopause, yet nobody was talking about it. And nobody was putting this on their intake form as a concern. But if I would ask, almost everybody was experiencing pain, burning, itching, you name it. But, it was such a low priority to them that they didn't bring it up, or maybe they were embarrassed, or maybe there's stigma. And so I just got interested in it. I wanted to ask everybody, and I wanted to learn more. And, we have to make product recommendations. And so I was recommending products, and we were in the middle of the pandemic. There was a lot of things that my patients didn't love. They didn't want to have to order. They didn't share an Amazon account with their kids. And so I was walking into pharmacies and finding nothing that I liked, nothing I felt good about recommending. As far as lubes and moisturizers, there is a whole science behind them that nobody talks about. I think you walk in, or the average person walks into a drugstore and they see 15 different lubes on the counter, and you just assume they're all the same, and they're not. And so I didn't know what to recommend for my patients. I had nowhere to send them to physically pick something up. And so I ended up working with a compounding pharmacist locally, and we were compounding products for my patients. And, after a lot of prescriptions, I said, there has to be a better way to do this. How can we reach more people? How can we normalize this conversation? Not just like, I want to have great products, but I also need people to learn. I need the public to understand that these products are not all the same. And I need people to ask questions. And I really wanted to be part of that change and that movement. And so that led me to product development, which led me to Iris. And now I love to talk about sexual wellness and vaginal changes that happen in menopause, but also other times in a person's life.
One of the things that I've always been so fascinated by with this discussion is like the intersection between like personal products and what would maybe consider to be like a medical product, and how different. And I was so shocked to learn at one time, years ago, and partly through my introduction with you, is that there is different regulations around something that's maybe considered to be medical grade versus something that's considered to be a beauty product or a personal care product. And so I think if we went to the drugstore and we were going to grab like a shampoo that was for shiny hair, we read the ingredients on it, but we don't know the concentration. We don't know the dose. We don't really ever, put our one shampoo up against another shampoo and compare the ingredients all that much. And that speaks volumes to sort of I'm not going to say it's a lack of regulation, although maybe, around personal care products, but that they don't maybe demand the same level of science on the label, or the consumer doesn't need the same level of science. Whereas if we dispensed medications in the same way, right, and we were like, we didn't disclose all the ingredients, we didn't tell you how much was in it, we'd have like a real problem with it. And then there's vaginal products, which like come in the middle, and the science, the dosage, the pH, the osmolarity matters, but the labeling that for those personal care products does not demand that level of accuracy or detail. And it really puts us in this unique situation. And I would love for you to sort of talk a little bit about that, so that our listener who's unaware, now that they're frantically opening their night table drawer to read the label of their lube, that there is this challenge between like medical products versus personal care products with respect to ingredients.
Yes. I too was blown away when we were developing the products, because I was so excited to like call Health Canada to say, hey, like what can I get labeled on here to say that this is safe and that there's science to back it, and disappointed to learn that a lube was considered a cosmetic, meaning that you can't apply for anything, and that there was very little regulation on as far as what went in it, and that the World Health Organization has recommendations, but you don't have to follow them. And so, yeah, that was shocking. And that is something that I like to talk about, because people don't know. You just kind of probably pick the cheapest one on the shelf, right? And so some of the things that were important to me when we were formulating were like pH. That might be the easiest for us to kind of like go through. So, as I like to say that the products were made with the menopausal person in mind, but then as we started working with different people, we realized that this is a great product for a lot of people, not just people in menopause. But when we talk about menopause, one of the biggest changes that happen vaginally is that you have an increase in the pH. And with that increase in pH, like it's caused because of the drop in estrogen and the change in lactic acid. And so you have an increased pH. That increased pH increases your risk for infection. And so a healthy vaginal pH is around 4.5. And then it might change to like a 6 or 7 in menopause, maybe higher. Everybody's a bit different. And so when we're using a product, we want to use a product as close to like a healthy vaginal pH as we can, because if the person is already sitting high, we don't want to like bring them even higher. We want to try to bring them down to like a lower, more healthy pH, we'll call it. And so that's the first one. We had to have a pH that was, 4.5. That nobody cares if you do that. Like nobody cares if your lube is the right pH, and no packaging will say what pH their lube is. So that was one of them. Another one was osmolality. And so osmolality being the movement of water. And so if your product has a really high osmolality, the product will pull water from the person and dry out their tissue even more. And so while you're using the product, because we're talking about lube, while you're using it, it feels great because it's doing its job. In the long term, as you're using it, you might actually be drying the tissue out. One of the doctors I work with like described it as like scuffing some of the cells off. And like that is what happens when you're using something that is hyperosmotic. So that is another thing that we looked at that is not looked at by or not like mandated to hit a certain level. There's recommendations and then there's optimal, right? Other things like glycerin, right? And I'm not here to villainize glycerin. It's not the worst ingredient, but it is only really safe vaginally in certain amounts. And so again, like you said, because you don't need to disclose how much is in there, you don't know how much glycerin is inside of these products. And it will make the product feel really good, but it also can be irritating and it can increase risk for infection. And so when we don't know these things, it's really hard to choose. And so I have like reached out to some of these companies to try to get some of this information and it wouldn't get shared. So
yeah, it's funny. Like even in one of my previous lives, I wrote for a company that created a lube product, and I asked for ingredient listings so that I could do an accurate writing. I was like, well, if we want to write about this, like let's talk about all the amazing things that are going on with this product. And they were like, oh, that's not public information, and some of this information we don't know. And I was like, oh, that's uncomfortable for me to try and write about a product when we're trying to like promote the positive, amazing things about it, but these numbers are often not disclosed. And I think it brings up an interesting thing, because I think if we think about like lubes that are going to be irritating, right? I don't know. I'm an old millennial. Like we all have had the like horror of the cherry flavored burning hot lube or whatever, right? We've all had that experience. Right? It's
yes, not just you.
Not just me. And so we imagine like irritation with lube being something at that level. But that's not actually what we're talking about. We're talking about like unflavored, like supposedly, healthy, well, good lubes with chronic use not actually supporting you. I used to joke with my patients. I'd be like, it feels good for the minute or half a minute, depending. But then, it's the long-term use. And one of the things I find so fascinating about this conversation is because they're not in the open, these discussions, is that we will learn that women are using a lube as a moisturizer in many cases. So they're using a product that is not intended for daily application daily because of discomfort. They're choosing it for reasons, because it's the cheapest, or they just don't know any differently. But they're not having this conversation with anyone. So they're applying something vaginally without a discussion that doesn't have good labeling. And it can lead to so much more discomfort and really derail their sex life. Which we'll get to in a second. But I find this so fascinating. Like if we stack all of these pieces up around this discussion, it really leads to people having symptoms longer than they should and not being supported like they should.
100%. And that's exactly what I was seeing, which is why I felt so pulled into like talking about it and normalizing these conversations and teaching people. Yeah.
Let's talk about arousal and sex drive and all of that. Let's move into that part of the discussion, because I like what you said when we opened, that people would deprioritize this part of the discussion around their health. I always found when I asked people about vaginal dryness, they would say it like as if it was like plain as day, of course, but then it was so not an important part of their health. And I don't, this is the question I have for you. Like, is it because they don't think that it's something that can change? So why focus on it if this is just, the way it is, that there's nothing we can do about it? Is it about, still like feeling this like insane level of disinterest? And so people put other parts of their health higher on the priority list. Like what's been your experience around that, Dolores? Why do people deprioritize their sexual health as part of their health?
I think that it's a good question because it's true. That's exactly what I see clinically too. And I think that the biggest issue happens because of this lack of education, really. And so a lot of the times we can think back to like, what was our sex education? Because I know my sex education was STI and pregnancy prevention, and that's about it. There was no conversation of communication or asking for what you need or pleasure or anything like that. And so how were we taught about sex? How was my patient taught about sex? Well, Hollywood, and maybe their partner, like what their partner saw, maybe porn, like that's where they were taught about it. And that is all fake. And so then they see this stuff like, you know, I'm supposed to just have this desire and I'm supposed to see my husband and just like, oh my goodness. And that's not what's happening. And so then they think something's wrong with me. Something's wrong with me. And so they just don't even entertain the conversation, because that is a deeper conversation, is the desire piece, right? And so, I mean, way back into like the 1960s, they came up with this theory that, you know, it had to be desire, and then after desire was arousal, and after that was orgasm, and they had to come that way. You couldn't have desire, you couldn't have arousal before you had desire. It had to be linear like that. And if you weren't going like that, well, then something's wrong. You're broken. And so that's where the first issues are. And it's not as easy as take a supplement or use a vaginal moisturizer for these types of conversations, because I feel like I'm doing a lot of unlearning and relearning with my patients about this, right? And so like desire being the first one, but I like to break it down when somebody comes in, whether it be vaginal dryness we're talking about, or sometimes if they write low libido on their intake form, I think of 4 things. I think of desire, I think of arousal, orgasm, and pain. And so I try to, you know, there's assessments and questionnaires we can do with our patients, and they're great, but you really need that clinical one-on-one to take out, you know, life circumstances. Sometimes people have just had a baby, like those, the questionnaires can't do. And so talking to the person will help us. And usually I can divide it into those 4 things and figure out what category they fit into and go from there.
So define the difference between arousal and desire, because I think for some people, they would maybe consider those 2 words to be synonymous.
Yep. So desire is more of the wanting, right? It's like a dopamine. It's a want. It's very mental, emotional, right? And so, but desire, it has now been broken into 2 different types of desire. And so we have spontaneous desire, and that's usually what we see in Hollywood. That's what we see in the movies of, like, you know, you see your partner and, oh, I just have this desire all of a sudden right now, right here. Let's go. And then we have responsive desire, and responsive desire looks more like desire after responding to something, whether that be a moment of like connection, or it could be physical touch. It could be like anything that kind of like gets that spark going. And the research says that most people will experience responsive desire if they've been in a long-term relationship. And the average timing for that is 6 months. So if you've been in a relationship more than 6 months, average, you are going to most likely, this is in women, you're going to most likely experience responsive desire, not spontaneous. And so a lot of times just explaining this to my patients that like you probably require some form of connection, however that looks, before you feel desire, like they're just mind blown, because they're like, yes. And I like to use my example of going to a party, right? We have some people who they wake up and they're like, get invited to a party, and they're like, yes, let's go. We're going right now. Let's do it. There's our spontaneous. And then we have some people who are like, oh, I don't really want to go to the party. Like, then I gotta get changed. What am I gonna wear? Like, I don't want to go to the party. But then they go to the party and they show up and they enjoy being there. And they're like, hey, actually, like, I'd like to stay at the party a little bit longer because I like being here. So that's the 2 types of desire. And you wouldn't believe how, when I explain that to people, they just feel so validated, because they're like, yes, I don't feel spontaneous desire much, and I thought I should.
Yeah. And it really speaks volumes to like how much circumstance can get in the way, right? For people where, you know, the day can be going great. You can feel like, you know, relatively connected to your partner, but then bedtime with your kids is an absolute shit show. And then, so even though maybe it was like on your radar, on your calendar, but now you're arguing about, you know, whatever. And now that the moment has passed, right? It's not like you can just skip over, you know, the emotions of the evening and be just as ready. That would actually be a little bit more like spontaneous desire than responsive. Because how are you responding to this like horrific bedtime routine with desire for your partner?
Yeah. And it is so complex, right? And that is why this is sometimes so challenging for people, because it really takes the coaching to get through this and to explain it and to explain why you might be feeling a certain way, right? But then arousal, on the other hand, arousal has more of a physical aspect to it, right? So in women, we know that once we see arousal happening in the brain, there are different parts of your brain that kind of light up, but also we see physical changes. We see vaginal elongation. We see increased blood flow to the pelvis. We see clitoral enlargement. And so those are like the physical things that are happening. And you can have arousal before desire. And that's like some of the more like the models we're working with now are more that, you know, there's different forms of desire, but also you can have arousal before you feel desire. And some people require arousal before desire.
And physiologically, what's happening there where arousal is happening before desire? Like, how is that working on a biochemical pathway? Do we know?
That's a good question. I mean, I think that we have like thoughts and fantasies and stuff like that, but they require like a little bit of, you know, everybody's different, right? And so I was reading a study yesterday actually that was saying that a lot of women require connection before, and then they will feel connected, then they will feel arousal. They can literally be talking about something unsexual that they just feel this connection with their partner, and that can cause arousal. And then now that they're aroused and they're feeling connected, they might have the desire. And that is what it's typically looking like in real life.
That's so interesting. Sean and I have this like running joke, which he'll maybe be mortified that I'm sharing. But whenever we do something that is like so old married person for the other person, right? Like if he renewed my car insurance for me, I'm like, are you trying to have sex with me? Because it's like those things in your long-term relationship that like make you feel so loved that he knows that I cannot find those pink slips. I do not know where they are. I cannot print them and put them in my car. That is like the most attractive thing that happens to me during the day. Hey, someone getting my car insurance shit organized for me. But it's like so interesting because it's kind of like what you're saying here.
And that even brings up like, so there's this theory, it's called the heteronormative theory of low sexual desire in women partnered with men. Okay. It's a mouthful. And it's basically going through like, heterosexual like partners, when a male and a female are married or partnered, whatever, there's typically this, what we call the mental load. I don't know if you've heard of it, but it's this invisible load, or like I will often tell my patients, like you're an invisible project manager of your home. And you're not just doing the chores, but you're keeping track of everything. And you're not just actually physically changing the toilet paper, but you're remembering when it's time to buy more toilet paper. Or you're thinking, not just are you making dinner, but you also need to think, okay, like I made pasta yesterday, so I don't want to make that again. And I know this person doesn't like this. And what am I going to make? And then now I got to go buy the groceries. And so it's like just this mental load of things. And so that could create a lot of resentment between partners. And I mean, the research is pretty clear that like most of the time the woman is taking on this mental load. And so this can create some resentment and, you know, like, and then that might be creating a little bit of tension and relationship stuff that might interrupt the desire piece, right? And so there's so many aspects to this like thing that we once thought was just as simple as desire, arousal, orgasm.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us.
So of those 4 quadrants there, you also mentioned, so we've got the desire, we've got the arousal, and the arousal is like maybe the physical responsiveness. Before I move into those other quadrants, you mentioned before we hit record, which I think is a really great point that I want to bring up, is just around lubrication with arousal, because that's something that people almost imagine that they need to be physically ready in order to have penetrative intercourse or any kind of sexual connection. And yet you mentioned off camera there that this is why I want to bring it up, is that that's not always the case.
Yes. So in those arousal studies, that is one of the things that they have always looked at. So they're looking at like increased blood flow, but they're also looking at lubrication. And so a lot of people think and feel that if they are not experiencing increased lubrication in that moment, that they are not aroused. But that is it's a very different amount of lubrication that will happen for everybody. But also, if you're one of those people that are experiencing a little bit more vaginal dryness, maybe because of menopause or because you're breastfeeding or because you're taking certain medications that increase risk of vaginal dryness, you may not produce any lubrication. And it's an interesting conversation even between partners, because your partner may think that you're not into this, but really you are. And that's a conversation I have often with my patients too, where, you know, they come in and they're like, I've never needed lube before. Like I've always self-lubricated. And so your body's changed, like the hormones have dropped, and that is not. And I love, debunking that myth that lubrication does not mean arousal. It just might be a part of it, but it also might not be. And so just use lube.
Yeah, it's funny because it's like I don't know. It's like we almost assume that if you're going to use anything vaginally, that it means that something is wrong or that something is broken, versus like, what a luxury that this has been invented so that we have the ability to make it more pleasurable and more moisturized or more whatever, that we view it as like, you know, that there's the stigma associated with it is that there must be something wrong if you need it.
Yes.
Versus like, what a luxury this is.
Yes, exactly.
So let's talk about the pain piece before we go over to orgasm. But how much is that interfering with people in terms of like their sex life and arousal? Like how much is that interfering, or how loud is that part of the quadrant getting for patients?
The pain piece it's interesting because what happens is painful sex obviously is not going to be a type of sex we desire, right? And so when I talk about desire with people, I always say like, you also need to be having sex that's worth desiring. I don't desire doing my taxes because I don't enjoy it. And so it needs to be worth desiring. And so if you're having painful intercourse because of vaginal dryness or because of whatever, like you just had a baby and you're still healing and have scar tissue, you're not going to desire that. And so that's where like all these quadrants kind of like affect each other too. And so pain's a big one. And there's definitely dryness is there. And for a long time, we didn't talk about it. Now we're talking about it in the landscape of menopause, but dryness happens to a lot of people. There's like some thought leaders in the space who are really trying to coin the term genitourinary syndrome of lactation, because just like the hormones drop in menopause, they also drop postpartum, and they continually stay low if you're breastfeeding, right? And so that dryness and feeling is identical in some people that breastfeed. And so they're trying to, we know that when we coin a term and like there's a name for something, it's taken a little bit more seriously in medicine. And so they are trying to coin this term to say there's people who breastfeed for 2-3 years and they are suffering sexually, or maybe not even just sexually, but with everyday life things, right? And so that needs to be thought of. There's medications that cause vaginal dryness as a potential side effect. There's lifestyle things like smoking that increase your risk for dryness. There's, I think of my breast cancer survivors, that certain medications that block estrogen. And so it's so much more than just menopause. And that's why I say, it was made with the menopausal person in mind. And then we've just learned so much more and met so many people that could benefit from these products and that are experiencing pain. But it even goes beyond dryness. Thinking about skin things like lichen sclerosis, lichen planus, pelvic floor tightness, vaginismus, like those kind of things.
And then how much, and I don't know if we know this, but like how much does anxiety or stress or, even just that lack of desire, how much does that influence pain?
Definitely. And it's all like a circuit, right? There's a like vaginismus, which is when the pelvic floor muscles like really tighten up and almost to the point that nothing can penetrate, not even a finger, a dilator. And we know that there's a big mental, emotional, maybe even trauma aspect to these people. So yeah, definitely mental health is playing a big role here.
And then let's talk about the orgasm piece. I think it would be interesting for our listeners to hear where the research does sit around sexual activity and orgasm and what the stats are in this moment. Because I think we see things floating around online now. It is talked about more than it has been around, sort of like the disadvantage for women in terms of trying to achieve and reach orgasm. Like, where does the research sit around those pieces right now?
Mm-hmm. So orgasm is like that climax of sexual excitement. And we know that there's a lot of benefits of orgasm. And so we see like improved sleep, we see stress reduction, we see improved pain, we see mood changes, we see immune changes. That's like so fascinating to me. But a lot of this conversation is around what they call the orgasm gap, where it refers to like that gender inequality as far as sexual experiences. And they look at like the different pairings, right? And so who's winning the race here is heterosexual men. And then after that is gay women. And maybe that's because of a little bit, what we think it's more of like a social thing and like our upbringing and stuff and talking about pleasure and female pleasure. And that, like I was saying before with Hollywood and like how this goes or how it's supposed to go, air quotes, is a little bit more male centric. I will sometimes ask my patients, like, when does sex end? And most of them have the same answer: when he's done. And so like, it's just this, and so it's interesting. And so we also see orgasm change with age, and that's probably because of the reduced blood flow in menopause. And so if we have less blood going to the clitoris, we're going to have less orgasm. I always love to talk about Freud when I talk about orgasm, because I thought it was so interesting that he said that clitoral orgasms are immature, and that if a woman was maturing sexually, she would start to have like vaginal orgasms, which is wild because we know that like 70% of people will never reach orgasm vaginally. So like, way to set some expectations. And so this is like where we were at, and this is what we were told. And so you can't blame people almost, right? Unless we start having more of these conversations and educating them on like expectations and what it could look like and how to reach orgasm and pleasure, and what's your pleasure look like, and how do you achieve that with your partner? Like, there's so much that needs to be discussed.
Yeah, it's interesting when I was working with patients, even talking about other things like vibrator use or lube or bringing things into the bedroom that they didn't need before. Again, I'm saying in air quotes. They, again, often saw it as that something was wrong or broken by bringing in these things, not what an absolute luxury it is that you have something plugged in on your night table that's going to help you with this, right? Mm-hmm. And we need such a different mindset and I think it's changing, right? I'm like hopeful that the 40-somethings right now are in a better position to navigate sexual health and menopause than maybe 1.5 generations above. But the women that are in like their 5th and 6th decade currently, the narrative that they've had and then sometimes have passed down is that those things shouldn't be needed or shouldn't be necessary, or that you need to keep it the same all the time, right? If you decide to bring something in at some point in time, that it means that there is something wrong.
Totally. And I mean, people feel about like this, even about vaginal estrogen, which is like a treatment, like it's a treatment for something. And so understandably that they would also feel weird or whatever about, or that like this is not normal or something's wrong with them if we, talk about bringing in vibrators and lube.
So as we're sort of like finishing that circle of the conversation here, Iris produces 2 products right now, a lube and a moisturizer. I know you and I have talked about this on the show before, the difference between those 2 products, but I think it's worth saying again. We've spent a lot of the discussion today talking around, sexual health and desire, which maybe makes us think about a lubricant first, but where does the moisturizer fit into the discussion?
And so I was so adamant to make the 2 products because they are different, right? And so there is some products on the market that advertise as both, and they're not the same. They are made different and they're used for different things. And so the first one being the lube. And so we did a water-based lube. Lubes come in all different types. There's oil, there's silicone, there's water-based. We chose to go water-based. We wanted to keep it body similar. We also connect with a lot of healthcare practitioners. They prefer water-based sometimes because they may use tools like dilators and whatnot. A little bit easier to clean up too. So that's our first product is the lube. And we did touch on that quite a bit. And then our second product is our vaginal moisturizer. And a vaginal moisturizer is what it sounds like. It is a moisturizer used vaginally for when there is dryness. And so that might be the person that's going through menopause. That might be the person who's breastfeeding. That might be the person on SSRIs, anticholinergics. There's lots of things that produce vaginal dryness. And the main ingredient or the active ingredient inside of our product is hyaluronic acid. And hyaluronic acid is studied for vaginal dryness in menopause to really just increase your own moisture. That's the job of the hyaluronic acid. You put it on and it just feels like, when you put cream on your face and it just absorbs in, that's what it does. It absorbs in, as opposed to the lube that sits on the skin and is used whenever there's increased friction. The hyaluronic acid, so the research on hyaluronic acid basically says use it every day for 14 days, like that loading dose, and then it can be used 3 to 4 times a week as needed. It is totally fine to use it every day if you want to continue to use it every day. The other beauty of this hyaluronic acid is it can be used alongside vaginal hormones because I'm a clinician and I do lots of vaginal estrogen prescribing. I am not here to say that this is better than estrogen. It can be used alongside estrogen, but also the beauty of it is just it's over the counter. People get access to this without a prescription. Like the wait times, at least where I live, are really long to see somebody who knows how to prescribe vaginal hormones. Like we are still living in an age where people are getting declined vaginal estrogen, even knowing how safe it is. And so it's a really nice place for people to start. And they don't even need to really have the conversation yet. If they're not ready, they can learn about it, purchase, use it, help themselves, and then see how it goes. And if they need to move up to more, they totally can.
I'm glad that you brought that up because it's funny when something has a prescription, there's so many barriers to compliance with prescriptions. And one of them is just the physical refilling, having to go to a place. It's not that accessible, or even see your practitioner to have something refilled so that you can go pick up more. I've always joked that I felt like vaginal estrogen could almost be in a vending machine with the level of safety around it. And yet there's a few hoops that people have to jump through to get that prescription. And it would be very common that people would get, their couple of boxes of vaginal estrogen, get started, run out, and then nobody has go refill my vaginal estrogen on their agenda. And then months would lapse between prescriptions because even if they had refills sitting at the pharmacy and I had written in red pen, circled it 6 times, please go get this when you run out. It's something that's available over the counter that they're able to at least even bridge between when they're, run out of their prescription or whatnot.
Mm-hmm. And that even just makes me think of our packaging because we were so intentional with our packaging that I really wanted to make this feel like a luxury experience because I know that when people walk in, they don't feel sexy having vaginal dryness. It's hard enough for them to talk about it. It's it's hard for them to talk about sex. It's even harder to talk about vaginas. And so they usually will hide their prescription and like put it where nobody can see. And I wanted to make it beautiful so that, you know, you would put it beside your toothbrush and use it twice a day, just like you brush your teeth twice a day, you know?
Yeah. Well, I love what you are doing, have done, are working on, Dolores. Like, would love for our listeners, if you could just share, like, what's your mission? How can they be a part of it? Where can we find you? How can we learn more? But mostly leaving them with that message around, like, how do you want them to feel after listening to our episode today?
I wish I could make people feel that everything they feel is likely normal and common, but that doesn't mean that you may not need treatment, and that there are great options available, and that not every option is the same. And so if you do your homework, and I love the idea of the podcast because you can just put your earbuds in and listen with no judgment, just listen and learn, and then make some educated choices for yourself. But if you want to find me, I'm on Instagram mostly at Dr. Dolores ND. You can also follow our Iris page, which is lovemy.iris. If you want to purchase, we are online, www.lovemyiris.com. If you use the code RIM20, you'll get 20% off a purchase directly from us. But there's a store locator on our website as well if you wanted to buy in person, because we are in some pharmacies across Canada.
Amazing. It's not very common, Dolores, that I feel so passionate about like one particular product. But I love watching like female founders who found a female problem, who are like relentlessly in pursuit of better education, better access, better products. So I'm like full supporter of your mission and what you're doing. And I can't wait to see what you do next. And hopefully we blow the doors off of this conversation over the next couple of years. Thank you so much for spending time with us today.
Thank you, Jordan.
That's it for today's episode of the Real Integrative Medicine podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.